All right, well, it is an honor to be here today. This work has been incredibly fulfilling, and it's a real pleasure to share with you the journey that we've been on. It's also a pleasure to be here today with a lot of folks from Washington. We've got quite a cohort here, so it's great to see so many friendly faces and folks from a couple years ago. So our initiative, wrong one. There we go. Helps if you have the right clicker. Our initiative was convened by the Washington State Hospital Association and the Washington State Medical Association, which is where I work. You'll hear me refer to them as WSHA and WSMA, WSHA being the Hospital Association, WSMA being the Medical Association. And I just want to tell you a little bit about each of these organizations so you kind of get a sense of who we are, especially within the context of us being conveners. So the Medical Association has been around for 125 years. We work on behalf of physicians and patients in Washington State. We have about 11,000 physician and PA members from nearly all specialties and practice settings throughout the state. Our mission is to provide strong physician leadership and advocacy to shape the future of medicine and advance quality care for all Washingtonians. The Hospital Association advocates for and provides value to its hospital members in achieving their missions and improving the health of their communities. WSHA represents all hospitals, as in 100% of hospitals are members of the Hospital Association, as well as health systems. And through leadership and collaboration, they strive for exceptional health outcomes in Washington communities by focusing on high quality, healthy communities, and sustainable cost. So the two associations, we've worked together, and I have spent most of my career in Washington, and I didn't realize how unique it was that a hospital and a medical association work together. But we do, and we do it really well. And we have a history of doing that. We worked on several initiatives like 100,000 Lives, ERs for emergencies, Choosing Wisely. We talk to each other in the state capitol and collaborate on different advocacy issues there. This is definitely the most formal collaborative we've had to date. And I'm going to share with you kind of that journey that we went through. But there's been huge benefit to us partnering between hospitals and physicians to do this work. So what I want to do today is talk to you about how we convened healthcare organizations and community groups to prioritize advanced care planning, and how we launched 49 teams from 27 organizations within a 2-year period. And I realize today this number's out of date. We keep getting new teams. I think it's 50-something from 30-something, but yeah. So good work. To start, I want to tell you about Dr. Farber. So Stu Farber was one of the first palliative care physicians that we consulted with when we first had the idea to do something more about advanced care planning. And he had just founded, at the time, the Palliative Care Center of Excellence at the University of Washington, and was widely known as a giant in palliative care. And I remember meeting with him in the fall of 2013. It was him and a couple other doctors, and we kind of let him know we wanted to do something. And they expressed skepticism about what it was that a medical and hospital association could do and whether we could do something meaningful in this arena. But it was worth a try. So a month or so after this meeting, Dr. Farber was diagnosed with acute myelogenous leukemia. 4 months later, his wife was diagnosed with the exact same thing. Less than 3 years later, he had died, and his wife died just earlier this year. Dr. Farber was outspoken about how lacking the medical profession was when it came to dealing with death and dying. He had a joke that he told during lectures about why oncologists weren't invited to open casket funerals, because they'll say, wait, let me try one last thing. Sorry to the oncologists in the room. Dr. Farber called his brand of doctoring narrative medicine, which focused on learning what was important to a patient, to balance treatment with wishes, values, and spirituality of people and their families, especially when it came to end-of-life care. After he and his wife were both diagnosed with AML, they had a lot of conversations about what was important to them, especially at the end of their lives. But his wife shared a story that even her own husband, this giant in palliative care, had a hard time saying when enough was enough. And she shares a story about their last time in the hospital. It was just a few weeks before he died. And she sat with him at the bedside and said to him, you know, if Stu Farber were our doctor sitting here with us, he would tell us it's time to go home. And he sat up and looked at her and said, yes, it's time. So she turned to the people at UW where he worked, the palliative care service group, to help the program's founder. The team came together, helped him get home on hospice. And Dr. Farber's son recalls his father telling him, so this is Dr. Farber saying that I thought I was going to die in the hospital, and here I am in my home, surrounded by my family, and I'm going to be here the rest of my life, and that is a miracle. So the reason I'm telling you about Dr. Farber is because of the immense wisdom that he gained and shared by being both a physician and a patient. Before he died, he made a call to action that I want to share with you today. So he wrote, professionally, I understand in a deeper way that death is not a medical event. It is a central life cycle event that we will all successfully complete, no matter how much medical care we get or don't get, how healthfully we live or don't live our lives. Death is a process to be lived, not a problem to be solved. Yet literally, every clinician Anna Lou, his wife, and I have interacted with is more afraid of death than we are. They focus on solving the problems of our illness with little awareness of how we want to live our lives. It's a paradox. The clinicians focused on treating the illness that threatens life, but the life of the person who is ill is invisible. It's critical for clinicians to embrace death as a normal part of life so they can accompany and guide the patients and families they serve through the sacred process of living until death. With rare exception, the clinicians who treated me have good hearts and care deeply, but they possess little or no knowledge of my thread. My thread is the narrative I use to make sense of my life. It's longitudinal, nonlinear, emotional, filled with contradictions, and integrates my life experiences into a coherent whole. It's within the values and meanings of my story that treatment decisions are made. What contributes to meaning and quality is not about living longer, but living a life that's consistent with my thread. Without knowing my thread, it's impossible for a clinician to provide respectful care. To the handful of clinicians who were patient-centered and understood my medical goals, I am eternally grateful. To the 4 clinicians who understood my thread, I cannot express the depth of my appreciation. This gap existed with every discipline and left me feeling that, while well-meaning, most providers were mostly nuisances and at times major annoyances in my daily life. Palliative care is a workaround, not a solution. Radical system change is needed that includes fundamentally new alliance among patients, families, and professionals. I hope that Dr. Farber would be proud of the work that we have done in Washington State. Our vision is that everyone will receive care that honors personal values and goals at the end of life. We do this through conversations, and we're taking a 2-prong approach of helping the public make informed decisions and preparing healthcare organizations and community groups to support patients and individuals and families through that process. We have several programs underneath our initiative. The most mature is the Advanced Care Planning Program, this First Steps program that we've launched. And we have several other areas where we're working, professional development, so communication skill building with physicians and advanced practitioners. We want to stand up a state repository. We're wrestling at the state capitol with completion requirements for advanced directives. I feel everyone's pain in that arena. And then, of course, we couldn't do any of this work without community engagement. So on the next slide, there's a poll question, so if you want to go ahead and get your phones out. I want to talk to you, just kind of introduce the concept of the Convener Model. And I think there's a lot of conveners here, so you're familiar with this, but there's some key elements here that we'll go through. So it brings people and organizations together to address a complex issue, uses influence and authority to call for collaboration, serves as the organizer and administrator of the collaboration, and creates a platform for the collaboration. So what I'm curious about is, in what ways are you a convener? So the 4 are listed, and then you've got options. We do all of these, we do most of these, we do at least one of these, or what's the question? Excellent. And what I'm seeing is some answers changing, so kind of a realization, oh yeah, we do all that. Excellent. So, really, if you're working on advanced care planning, you are a convener in one way or another. Remember that Dr. Farber called for radical system change that includes a new alliance among patients, families, and professionals. So you're all conveners creating these new alliances. So how did we get where we are? This is one of the most common questions that I get is how long did this take? And it took us time. So this is kind of the first 4 years of our work, starting in 2013 where we came together and we had that meeting with Dr. Farber and other physicians and said, we want to do something about this. And Wish and Wisma committed to each other that we would work on it together. In 2014, we formed our advisory council, which at the time was called a work group, and set out guiding principles, vision, and landed on a rough strategy. And then we also started working on our governance and oversight structure. In 2015, we really laid the foundation for the work. And it was one of those years where we'd landed on what we were going to do, and it took almost a year to launch it. So it was frustrating. We just wanted to move faster, but there's a lot of foundational work that needs to happen. We got buy-in from the CEOs and CMOs. We did contract negotiations both between the hospital and medical association as well as with respecting choices, got our staff on board, faculty on board, kept going with the advisory council, and spent a lot of time recruiting our early adopters for our first cohort, maybe too good of a job. And then we launched in 2016. Kim and I are presenting a workshop tomorrow at 11 where we'll go through how we run the collaborative. This is more about how we launched the collaborative. So if you're interested in kind of diving into the weeds, join us tomorrow. So this is the structure, kind of the org chart of our different organizations. So again, Wish and Wisma are the official co-sponsors or conveners of this initiative. And we established what we call an oversight committee with 2 people from each organization, so it's made up of 4 people. No one has a majority vote. And that group oversees and monitors the strategy and the progress of the initiative. And then we get a lot of input from an advisory council as well as a medical officer collaborative, which I'm going to tell you about. We used an iterative approach to our design and development, and we were very interested in understanding what our members needed, what healthcare organizations needed, community groups, patient groups, general population. And so what we would do is kind of we'd design something roughly, bring it to a group, they'd pick it apart. Sometimes they'd just send us entirely back to the drawing board, we'd start over. But it was really great to get that input, and then we'd come back to them with something better and get input again and keep refining it. And we also did this not with just one group, but with all of those groups. So we were getting a lot of different input from a lot of different folks. And what was really impactful about this is that everyone felt like they had a hand in designing the initiative. So by building the initiative, we were also developing engagement and support for it all along. So getting into the weeds a little bit more, looking at the tasks, the things that we wanted to do were clarify the purpose of the collaborative. There's a lot of work to be done in this arena. Develop a preliminary list of stakeholders, and think about who we wanted to invite to the table to inform the work. We also got high-level stakeholder buy-in, as well as intellectual and financial support. So the first step there is to clarify the purpose. Wish and Wisma were both really engaged at the time and continue to be engaged in the nationwide readmissions reduction effort. And every time we talked about readmissions, someone would bring up advanced care planning. And it was clear everyone wanted work to be done in this area, but they weren't quite sure how to tackle it. No one had quite cracked that nut. So we brought that topic to our medical officer collaborative. Now this group is, we convened them about 10 years ago. It's CMOs from all of the hospitals and health systems and large medical groups around the state. They meet 3 times a year, and they come together to, what we wanted to do is provide a forum for these senior leaders to come together and work on patient safety. and set competition aside. It's a unique place. CMOs are usually the solo person in their organization. They don't have peers other than outside their organizations. We wanted to bring them together. And they have established calls to action, and honoring choices is one of 3 of their call to action items and has been for about 6 years now. So this, the other key thing that they did was help us, again, clarify the purpose, and in particular name that they wanted to move the conversations upstream. We heard that over and over. We've got to move these conversations upstream. So we ran that concept by our boards and got the thumbs up to prioritize the work and go forth. And I really commend our boards for taking this on and recognizing the importance of advanced care planning as part of preventive care. So you always want to start with the why. This is one of the first slides that we created. It's changed over time. But as we were developing our charter and our case statement, there were some key pieces of information that everyone kind of kept talking about. So, essentially people know that talking about and writing down your wishes are important, but most people don't do it. And there's a misalignment with the care people want and the care they receive, and that results in added trauma to loved ones. So this is kind of our elevator speech about why this work is so important. One of the key things we did was an environment scan. We looked around the state, and we've got some really wonderful health systems and community groups that were already doing advanced care planning. We saw pockets of excellence in Whatcom County, Pullman, Group Health, which is now Kaiser, and Providence Health and Services. And we noticed that they were all working with respecting choices. We also got content expertise we had an IHI consultant that we worked with. We got to be a fly on the wall for the Conversation Ready project, which was about 8 or so healthcare organizations that came together once a month or so to talk about how they were addressing this. And then we knew that in moving the conversation upstream, our target audience for this work needed to be primary care physicians. So we engaged them. You often have your champions as palliative care physicians, and we knew in order to get full buy-in, we needed to get primary care physicians at the table. We had patient advocates, all the healthcare organizations, of course, community groups and state agencies, different collaboratives that were at work there. So through this environment scan, we found that several organizations were already working on advanced care planning, but they were doing it on their own, and they were doing it in their own way. And we knew that there was a lot we could learn from each other, and that there would be great benefit if we could come together and collaborate on this. So our general concept was that we wanted to bring people together to identify the top priorities for our region and work together towards shared goals of honoring patients' choices. So we convened in 2014 a large advisory council. We had about 30 folks, and we were fortunate. The Hospital Association at the time had a massive conference room, and we'd squeeze everybody in there every other month for a year. And folks would fly in for this meeting, which we were very appreciative of. They just really saw the value of it. So we had every major health system represented. And when I say representative, these are senior level. It's often CMOs, and if not, it was a delegate of the CMO or some other type of senior level person who was participating in this. We had all the large medical groups, large and small hospitals. We had professional organizations, which were fabulous at the table. So State Hospice and Palliative Care Association. We had insurance companies, several of them at the table. County alliances, state agencies, so the area agencies on aging. We had our Pulse Task Force co-chairs. And we have what's called the BRE Collaborative in our state. And it's a governor-appointed group to reduce variation in healthcare. And we had strong alignment with them in 2014. They picked up on end-of-life care as a topic that they wanted to prioritize. They picked 2 to 3 topics a year. So they researched it and wrote a detailed report about the issue and how to fix it, and honoring choices was heavily featured in that report. And then we also had our IHI consultant there as well. So we met monthly in 2014. We've moved it to quarterly. We now meet probably 2 or 3 times a year at this point. It was led by a physician chair. It was actually a CMO of Providence, which is our large health system in the state. And that was impactful to have someone of that stature chairing this committee and leading the work, and she continues to be our chair. And then it was staffed by senior staff at WSHA and WSMA. We had several work groups that met in between those bi-monthly meetings, looking at training and tools, goals and measures, advanced directives. And one of the key things here is how actively we engaged with everyone. So we came with some content for them to wrestle with, and we pretty much sat quietly and listened. And they picked it apart, and they told us how to fix it, and they had arguments about which approach to use. And we didn't always have time to hear everyone. There were a couple folks you could tell really had something to say, and we'd seek them out after and have one-on-one conversations with them, and just got some amazing content and guidance from them. This is culture change. It's a different approach. And so getting a group together, it was powerful and impactful, but you don't necessarily hear that voice out ahead. And so it was really helpful to have those one-on-one conversations with folks. Sorry, I forgot that I had a build. There you go. All right, so in that first year, we developed our charter, established the guiding principles, set our vision, completed an environment scan, both of Washington State, and then we also looked nationally at all the resources that were available, ultimately recommended a resource, and identified our goals and measures. That's a grossly oversimplified bullet. That's hard. All right, so our guiding principles that we landed on, we use this slide a lot. And we came at, it's old, it's 4 years old now. So what we all agreed was we wanted to move the conversations upstream. We have a diverse population in Washington. We wanted to make sure whatever we used was culturally sensitive, that it be sustainable, and that it complement all the great work that was happening. And of course, standardized. That was the most common thing. Patients are confused about advanced directives and advanced care planning, and they've done the conversation project. Are they done? There's just all sorts of confusion out there. And then we wanted to be results oriented. So from the beginning, we had some great people on our committee to help guide us through that. So the ad hoc resource subgroup looked at a lot of about 15 local and national resources, Respecting Choices being one of them, and kind of cross-checked them across a bunch of criteria. And the key here was how thoroughly this group looked at it. We actually came in with a recommendation that we didn't end up going with. We thought we had the tool, and we were told otherwise by our group. So ultimately, all arrows pointed to Respecting Choices. It checked all the boxes. This was what we wanted to do in our state. And the key things that we noticed about it were that it's an ongoing process of communication, that it's a part of preventive care. And the thing I heard over and over from, especially from the palliative care champions, was they'd been at this for decades. They had tried every which way to implement an advanced care planning program of some sort or another, and they weren't supported by their organizations, and it wasn't sustained. And so they were very compelled by how systemically the work is supported in the Respecting Choices model. That really resonated with them. So once we got that recommendation from the subgroup, we went around back to all these groups and found that, so this was our buy-in process. We'd really done our due diligence and looked through all of this. But we also had some adaptation. As Stephanie mentioned, there was a lot of change that came. So it took a few months for us to go back to all those groups again and get their buy-in and make sure that they would support us if this is what we wanted to do. So that brings us to our third task of a convener, which is to secure high-level stakeholder buy-in as well as intellectual and financial support. We had senior staff from WSHA and WSMA, so my counterpart, the Senior Vice President of Patient Safety and Quality at the Hospital Association, and I were out talking to everybody. Any chance we got, we were meeting with folks. We have access to our boards, we're on executive committees and sit at the board meetings and can get ourselves on the agenda, and we presented at every board meeting and executive committee meeting that we could. The two of us also ran the Medical Officer Collaborative, ran that agenda, so we'd insert ourselves there and talked about, actually Honoring Choices has been on the agenda every single meeting since 2014. And we give updates. We also pull people from the audience to tell us what they're doing in their organization. And then again, we had that senior level representation on the body that built this. And they were decision makers within their organization. And so they could go back in and say, hey, I helped build this. I really think this is what we should do. Let's adopt this within our organization. We could also partner with them to get CEO buy-in from within their organization. They told us who we needed to talk to. We held a ton of info sessions. We met with organizations one-on-one. We also had held webinars where anyone could join and hear what we were up to, what we were planning to do, what we would expect from organizations. And then the CEO commitment was really important. And by CEO, I'm talking both about the CEOs from WSHA and WSMA. They had a lot of work ahead of them. They were very invested in this, and so it was really important that they were fully engaged in this. We also had buy-in from the CEOs from all of our partner organizations. We actually had Stephanie come out and lead a leadership engagement and buy-in activity with our CEOs and CMOs, which is something we do about every other year. And we asked at the end for them to pledge to participate in this, and they all did, which was fabulous. Later on, we asked them to sign statements of interest. They also were key in our fundraising efforts. So we involved them in the feasibility study interviews, so they got to hear what it was we were up to in a very safe environment where we were just asking for their input without asking for anything else yet. And then we went back and asked them for a donation. And then for those who gave, we asked them to be on our campaign cabinet. So we just kept pulling people in any which way we could. And what this did was it gave us lots of opportunities to make sure that the CEOs were on board and supportive of the initiative. And we already knew that their staff were, and it's really important to have the CEO there. We decided to do a formal statement of interest process, just a 2-page document. We said what we were going to do. We said what we'd expect from the organizations. And then probably the largest section on it is a signature section. So CEO, CMO, CNO, and whoever was going to lead the work within the organization all had to sign. We've actually literally pulled those out when organizations are struggling and saying, remember, you committed to this. And this, we put out a big push, media push for this. So, as associations, we have marketing communications. So we've got magazines and newsletters and all sorts of blogs and whatnot. And so we were pushing out every which way we could. And we kind of had a sense of who was going to be joining the initiative. But we actually had kind of a surprise group come on board, the Vancouver Clinic, which is presenting tomorrow. And they happen to be one of my teams, and I'm just super proud of the work they've accomplished. But they were not on our radar at all. We'd never talked to them. The CEO was relatively new, and he'd gotten the weekly rounds from our CEO at the Medical Association saying, hey, why don't you join? And they had a relatively new palliative care doctor on board, and he called her in and said, hey, let's do this. And they said yes, and so we got a statement of interest, and now they're just this amazing star of our initiative. So it just really spread, and everyone was kind of talking about it. So what was the effect? We ended up in our first cohort with 32 teams from 23 healthcare organizations. Every major health system signed on in the first cohort. We also had large medical groups and large and small hospitals across the state. We had hoped for 10, and you kind of overshoot, right? And so we were kind of shocked, actually, quite honestly, when we got 30 plus statements of interest back. And we thought, well, let's do it. I mean, this is what we wanted people to do, was join the initiative, and they have. So we are going to figure out a way to do this. We also had a shared vision because everyone had helped us create this. They knew our talking points. They'd heard us talking about them, and we could share slides out, and everyone was kind of on the same page. We also had content expertise and alignment across all the efforts. So even if someone was doing something more specific, they were aware of our first steps work and knew how to integrate it into their work. And so we just had a lot of alignment. We worked closely with the Pulse Task Force, and we're clear about our different roles and what we would be doing in support of their work. There was a really interesting thing that happened with the BRE Collaborative, which I mentioned, the governor-appointed group. So when they get done with their report, they send it to the governor, and the governor signs an official thing endorsing the report, passes it to the healthcare authority, and says, do what you can in this. And there's some really specific recommendations. So one of them was, that the state in some ways can be a first mover. So when they want to see other people make change, they do it themselves. And so the healthcare authority oversees the state employee benefit plan, and as part of contracting, I think it was 2016 or 17, they required anyone who's going to be providing care to a state employee had to have an advanced care planning program in the works, and namely the Honoring Choices program. So, and what was great was that we'd already worked with all those organizations. They were already at the table, so it reinforced them staying with us and keeping engaged and really committing to the work. We also saw them recommend that Medicaid reimburse for advanced care planning, which we do in our state now, so in addition to our Medicare codes. We also had insurance companies at the table. And so the lever, they adopted that reimbursement, and so Regents, one of our blues in the state, reimburses for advanced care planning conversations. So it was great for people at the table to go back to their organization and find a way to support our work. So this is what it looks like. You can see our population density in Seattle and Tacoma, and then, but we've got representation from across the state. I did not include our current map. It's even more busy than this, which is great. But we were pretty impressed with the breadth of organizations that we had. From our guiding principles, we identified that we wanted to have a standardized approach. And what we found was that everyone agreed that we should have a common advanced directive, but the problem was that everyone thought that everyone else should adopt their advanced directive. So we got an ad hoc work group together to help us think about the elements of an advanced directive, and certainly with the guidance of respecting choices. We probably looked at your guys' advanced directives. We looked across the country at what people were doing and pulled in all the pieces that we liked. The key thing was that it aligns with the basic advanced care planning conversation. And what we found was that organizations liked it, and most of them have adopted it. At a minimum, within their small test of change, some have gone system-wide. We also, Bonnie Bazell, our program manager, has put together some fabulous videos. They're short and sweet, and they talk about advanced care planning and what a healthcare agent is and what's an advanced directive, and they're a pleasure to watch. And then we push those out to all of our organizations to help spread even further. All right, so ultimately the buck stops with the Medical Association and the Hospital Association. So I want to talk a little bit more about how our two organizations have structured the work internally, how we do this. So we, in 2015, we started on our Memorandum of Understanding. I spent a lot of time with lawyers in 2015, a little PTSD from it. But it was great. I mean, you have to think of worst case scenarios, right? So we're Pollyannish about like how fabulous this initiative is going to be, and then you have to think about like every bad thing that could possibly happen and plan for it in a contract. So we did that. We established our oversight committee in that MOU. We delegated key functions and wrote down how we're going to work together. What are our expectations of each other? And then we also set out our financial obligations. The two associations together gave $500,000 towards this initiative. The WSMA has a foundation, which is a 501c3. We actually got advice from John Maycroft, who was at the Wisconsin Medical Society at the time. He said, if you have a way, run this through a foundation, and we did, and it was the best thing we ever did, so thank you, John. So all the donations are tax deductible, which is great. So we also, it's technically, if you're looking at it, we're the fiscal sponsor for the initiative because it's between two organizations. So I talked about delegating key tasks. The Hospital Association is primarily responsible for managing personnel and contractors, and we have faculty contractors. So they kind of run all the HR stuff. And then the Medical Association, in particular through the foundation, manage all the fiscal pieces of it. So the sponsorship, tax, we collect the donations and pay all the checks and all that. But we also are so while each organization is ultimately responsible for different things, we are consulting with each other regularly, especially in those first couple years. There were so many decisions that we had to make, and we were very deliberate about talking to each other. We overshared every decision that we were making to make sure that we were both in agreement. And it's the classic, like you have to go slow to go fast, and it was well worth it. So we're a couple years in on this. How have we kept it going? There, as you can see, are several bodies that lead, govern, oversee, advise, honoring choices at a variety of levels. And this takes a lot of communication. We are always talking to these groups. But this also provides us with leadership buy-in on a regular basis. We can continue to foster those relationships. Each of those rectangles together represent about 200 individuals who are serving in different capacities in each of those bodies. So we have a lot of voices at the table and a lot of people who work full-time jobs within their organization who are built-in champions for our work. They certainly feel a sense of ownership to us, if they're on our board. They're definitely invested in that, as well as within their respective organizations. So we looked for every opportunity to engage with leadership. We, again, went to every board meeting we could, annual meetings, leadership forums, one-on-one meetings. We used our newsletters and articles and emails. We were always getting input and incorporating those suggestions. That was really important to us. And Dr. Thompson talked about establishing accountability. I loved what he said about us being responsible for their success. And we really took that to heart. We wanted to equip our champions with everything that they would need to be spokespeople for this initiative. We wanted them to feel a sense of ownership. Oftentimes people would come to us and like, hey, can you come speak? And we'd say, no, you speak. You be the person. We're going to equip you with everything that you need. We want you out there talking about this. And then we also took every opportunity to celebrate. We knew that it was important. People enjoy the recognition of participating in this work. Bonnie got us a governor's proclamation for National Healthcare Decisions Day this year, did a press release with that. It was fun to be able to talk about that in a variety of settings. We've held a couple of our own Share the Experiences with our organizations. The Medical Association has a Patient Safety Award that we give each year. Last year went to the Vancouver Clinic for their advanced care planning work. This year went to Peace Health for their advanced care planning work. So any opportunity we have to amplify and talk about their success helps the initiative. We also did press releases. So we did them ourselves, but then we also did kind of template press releases that people could take and modify for themselves and insert their own quotes and give them to their local media with approved language about how we wanted them to talk about the initiative. So we wanted to make it easy for them. So I want to talk to you a little bit about our funding model. This is probably the second most common question we get. We gave a lot of thought to this. We originally thought we were going to do like a consulting fee or charge an annual fee for people to join. And it was actually the CFO of the Hospital Association, who was on our oversight committee at the time, said, why don't we just fund this philanthropically? And took us a couple months to get our heads around that. Did the math, crunched the numbers, and we figured we could do this. Let's try this. So we hired a fundraising consultant to help us with it because we didn't have the internal expertise to do that. But we ultimately decided to be 100% philanthropic, which meant there was no fee to any organization to participate in this work. So all organizations from all sizes, all financial capacities, everyone has access to the resources and tools within our region. And that really removed any barrier to participation other than the time it takes within your organization to do the work. So wrong side. So we have so far raised $5.5 million towards our $8 million goal. That will fund our first 7 years of the initiative. Again, we offer everything at no charge, and there's no financial barrier. There are a few things that went into this success. We had, again, leadership and organizational engagement all along the way. And in addition to having them help us with the program design, we also engaged them in our fundraising effort. We hired a fundraising consultant. We had them on board for about 2 years. And then our poor CEOs, we had them all over the state, mainly 2016, 2017. But anytime we were asking for 100,000 or more, they went to that meeting. And sometimes both of them went. And it was just, it's very impactful for a CEO to CEO to do that solicitation. We also met a lot. So we had weekly calls with our fundraising consultant, a lot of work in between meetings. And then we had our campaign cabinet, which was a really powerful group of people, so CEOs of all the large health systems who had given themselves, and then we would partner with them to go out on a solicitation to ask another CEO from another hospital. There's magic in that. All right, so just to wrap it up, I want to share some of our lessons learned. And kind of always got to start with your challenges and barriers, right? That's where the richest learnings are. Culture change is hard. It's really hard work. And it takes time. I think one of the things you have to be really careful about is that decisions aren't made based on the old way of thinking. We have to change the way we think about person-centered care in order to make meaningful changes in practice. And I think we're still struggling with that. The other big challenge, we did this really fast, and we were building the plane as we were flying it. It was tough work. We were literally creating forms and tools like a day or two before we would send them out to our teams. We have teams here, you probably could tell that, but we made it work. We had teams that were launching. We were consulting with them through the launch as we're on the back end building an Excel sheet so that they could send us their data, which was going to be due in like a month and a half. So there was a lot that we had to build on the back end. If you don't have to do it this way, don't. But if you do, stay a couple steps ahead. It is possible. Just have a great team and be ready to move fast. I think we've talked a lot about this today, changing leadership. I mean, you just really can't overstate the impact that this has on your initiative. And I think it's good for us to remember our own journey. We didn't all just arrive fully aware of the importance of advanced care planning. We had our process. And so as new people come in their leadership roles, we need to take them through that journey. They have their own process. They also bring really fabulous, fresh ideas. And so be very deliberate about bringing your new leadership on board, both internally and externally. So within our organization, we experience that ourselves, but then also there's a ton of change in healthcare, which brings us to the next point, changing landscape. So we really launched in 2016. Everyone was understandably distracted in 2017. We struggled. It was a tough year. Our teams were telling us, we're trying, we're holding on, but our leadership is looking elsewhere, and totally get it. So that was in Washington, D.C. In our own Washington, we had a lot of changes ourselves. So a lot of mergers and acquisitions, a lot of incoming and changing leadership across the board. And so there's more we can do, but we've done a lot to work with those leaders to re-educate them, re-engage them, and get them to recommit. We actually had, because of that medical officer collaborative, that was one of the topics of the presentation was, hey, it's been a couple years. I know you guys have been looking elsewhere. Focus back on honoring choices. And I challenged them all to go back and talk to their ACP coordinator and see how it was going. What were their successes and what were their challenges? And I heard back about a month later, one of my other teams, the Everett Clinic, their ACP coordinator said, hey, our CMO came up and asked me what's going on. That was kind of weird. And oh, yay. And he said, I'm going to take this to the C-suite meeting and I want this on our strategic plan. And so that was back in June. I just talked to her 2 weeks ago. They're now having a formal strategic planning process. They're going to set their goals for next year and set a 5-year plan. And this is the Everett Clinic, which was recently merged with DaVita, which was then gobbled up by Optum. I mean, they've been distracted, but to have that recommitment was just really powerful. The next one is questioning how versus what. So we certainly had our struggles. We had some teams that dropped out. It was really difficult. And that's on us. We heard criticisms about the program. Everyone kind of combines the whole thing together, right? We still hear people referring to honoring choices as respecting choices and vice versa, which is fine. But when we looked more closely, we really found that what they were struggling with was how we were implementing the program, not what we were implementing. And so it's just really important to look at how you're doing it before you start thinking about changing what it is that you're doing. So risks and benefits of the Convener Model. Decision-making took time, both between the two associations. We did a lot of talking, but then that iterative process, it took months to get back around. In the end, it paid off, so patience was important there. We also found that it was challenging. There were so many times when I wished I was in the organization and I could just say, this is what we're doing. And instead, I mastered my leading by influence skills. So hone in on that. Some of the benefits are the power of the collaborative. That's something that our two associations talk about quite a bit in other efforts as well. So if we're all talking about the same thing and we've all agreed to row in the same direction, that can be really powerful. And it was also great to have such long-standing associations back up the initiative and say this is where we're going to focus our effort. So, we started big, and that had its pros and cons. You heard me say about building the plane while we were flying it. We also admittedly sacrificed customization in the interest of efficiency. We had 32 teams to get through implementation plans, and we brought a lot of people together. And so it was hard to really dig in on a particular organization and see what's going to work for you. We've taken a step back and are much more focused on using that customized approach. We heard Amy Berman yesterday talk about, I'm going to try and say it right, being cooperative. Did I say it? Coopetitive. I don't know, is Amy here? She's going to somehow help me. But we've referred to it as positive peer pressure. So while we don't compete on patient safety, you can bet there are people from different healthcare associations that are paying really close attention to other organizations' numbers and outcomes, which we shared transparently. And then that learning collaborative. We have a lot of organizations on Epic. They were getting their IT folks together to talk about how did you do that? What was your scheduling process? How did you set up your dashboard? So I want to share with you some of our key data before wrapping it up here. We've had over 3,400 conversations since we started. That's a 54% increase over our baseline, which was 24% of advanced directives on file. I'm sorry I said that, but we've had a 54% increase in advanced directives on file, which is over the baseline. 92% of our organizations have modified their EMR to include an ACP dashboard. So again, we're really focusing on laying the foundation with organizations, and that was a key measure. We recognize that the gold standard is for healthcare agents to be present at the conversation, and that's happening 61% of the time, which is really exciting. 90% of conversations are getting documented in the EMR. And our advanced directive on file rate is 37% for those who've completed an ACP conversation. And of course, the evaluation results are really high. The facilitators really appreciate the training that they got and love doing well, doing a good job at those conversations, and all of them are because of that standardized education. So those are the data for our individual conversations. For group sessions, a lot of our teams have moved to group sessions, about 15 or fewer people in a session. And what we're finding, folks have done 90 so far with over 1,000 people there. And healthcare organizations are always looking at efficiency. So this is a wonderful way to make the most of your limited resources. And the evaluation results are still equally high, which is great to see. All right, so just to wrap up, I actually got this from a Collaborative Leaders Network. It's a great website with all sorts of great resources if you're a convener. And I pulled out some of the key items that I really liked from their checklist. First is to identify a need that will benefit from a collaborative approach. Advanced care planning is surely that. Verify that the time is right. It was for us in 2015. We hit that bump in 17, but it was definitely the time to do it. Ensure co-conveners are clear-sighted and in agreement, and we certainly had that between us and the Hospital Association. Carefully design the initiative and ensure it has sufficient time and resources to generate long-lasting solutions. So it's worth investing that time up front. Build necessary bridges and convene stakeholders. Set and communicate the roles, responsibilities, and expectations. Monitor the progress and provide timely feedback and direction. Adjust the scope and timeline as needed. We have certainly made a lot of adjustments as we've gone. Honor recommendations. As a convener, your job is to listen and take in all that input that people are giving you and be grateful. People are doing this incredible work in addition to all the other incredible work that they're doing, and so we're always so grateful for the time that they spend with us working on this really important initiative. So as I mentioned, Kim and I are going to do a closer look at our convener model and talk about how we actually do it day to day with all those teams. And I want to recognize our staff. Mary Catlin's our new Senior Director for Honoring Choices, which is a huge milestone for us. We also have Michelle Kohanek here, who's new in August. I think you started, so it's fabulous having a new person working on the healthcare program. Bonnie's been with us for a few years and has done an incredible job with healthcare organizations, clearly, and she's very invested in community engagement, and so she's shifted over into that, which we're very fortunate to have. And then we couldn't do any of this without Mita, our executive assistant, who moves mountains. She absolutely amazes me. We also have a couple faculty that are here, Kim Stagner and Kelly Durgan. Very grateful for all the great work that they do. All right, with that, I want to thank you. I'm happy to answer any questions that you have. Looks like have about just a couple minutes. Okay.
Yeah, you say it. So we have a couple minutes.
We just have a couple minutes for questions. I'm good at doing what Stephanie tells me to do.
While we're waiting for questions, I'll yell. So this conference is about collaboration. Isn't this the epitome of collaboration? It's just an amazing example from start to finish. So thank you.
Thank you.
I don't see anyone getting up, so I will say thank you, Jessica,
Yeah,
and
thank
team
you.
for the wonderful work.